Hello everyone, it's me Dr. Ayaz Ahmed, working as an aesthetic dermatologist. Today I will discuss another important topic of dermatology. The name of topic is alopecia areata. Hopefully you will learn some good knowledge and subscribe my YouTube channel. Alopecia areata is a common chronic inflammatory non-scarring alopecia due to cell-mediated autoimmune response in genetically predisposed individual. Now, thing important here is that alopecia areata does not occur in any person. Those persons who are genetically predisposed may develop alopecia areata. This is the case of alopecia areata. You can see small patch of alopecia areata in the scalp area. When you see closely, you will find small patch of alopecia with round border or it is circumscribed. When you see closely with magnifying glass, you will find broken hair. These broken hair are pathognomic sign of alopecia areata. Although the cause of alopecia areata are many, but more common it is autoimmune. Another causes of alopecia areata are syphilis, lupus erythematosus, tinea capitis, and many others. We will discuss later on. Introduction and general description. Celsus in 20 BC to 50 AD described two types of alopecia. Number one, alopecia which is involved in head and beard area, and another type is the ophiasis which begins behind the head area. The term alopecia areata was used by the savages in 1763, cited by the Hebra and Kaposi. Robert Williams described alopecia areata in title of Prurigo decalvans. Epidemiology, age, sex and ethnicity. Incidence rate is very low, that is 0.1 to 0.2 percentage. The lifetime risk of having alopecia areata is 1.7 percentage. Age usually involved is 40 years of age. Sex is similar, it is similar in between male and female, and ethnicity is also similar. Pathophysiology, it involves autoantibodies as I have already discussed. Serum autoantibodies also occur in a hair follicle leading to depletion of CD4 and CD8 count. It has genetic association, especially MHC complex 1 gene have been noted. Immune privilege. Normally, there is low or absent MHC class 1 protein expression in lower follicular epithelium. This low or absent MHC class 1 protein expression is mandatory for the follicular cell growth. Immune privilege have also been seen in other areas of the body, for example, testis, anterior chamber of eye, in anterior chamber of eye. Those who are genetically predisposed individual, as I have already discussed, interferon alpha upregulates the expression of MHC complex 1 protein and NK cells activating ligands in follicle, leading to collapse of immune privilege and attack by CD8 plus cells. Cytotoxics plus NKG2D plus cells are the main pillar. JAK inhibitors have positive effect of hair growth. Pathology. Activated T cell, especially CD4 cells, macrophage, Langerhans cells, cell expressing NK cells marker are involved. Follicles are not destroyed in alopecia areata. This is very important thing. Follicles are not destroyed in alopecia areata. It means the patient of alopecia areata may regain hair again subjected to condition. Anagen follicle do not develop beyond anagen in a stage 3 or 4 stage. Genetic. Genetic association have also been noticed. The predisposing factors are family history, which is really positive, with HLA DQB1 asterisk 0301 and HLA DRB1 1104 gene have been seen. Clinical features. Clinical features are circumscribed hair loss, smooth patch with exclamation mark, or you may say broken hair sign, usually seen at the margin. Non-pigmented white hairs are spared in alopecia areata. This is very important. Means alopecia areata usually affects pigmented hair. Those hair which are non-pigmented hair, alopecia areata will not be seen in them. Involved nail in alopecia areata shows fine stippled pitting of the nails. Trichonychia or atrophic dystrophy may be seen in some cases. Differential diagnosis. So there are many other conditions characterized by alopecia areata. So we usually differentiate it from the other conditions. The other conditions are tinea capitis, trichotillomania, scalp inflammation, mild scaling disorders, early onset of scarring alopecia areata, SLE, syphilis, and drug-induced alopecia areata. So these are the conditions which are need to be differentiated from actual alopecia areata. Classification. Conventionally, uh, alopecia areata was classified as patchy alopecia, alopecia totalis, and alopecia universalis. In patchy alopecia, there is a circumscribed or round patch, usually in the scalp or beard area, have been seen. In alopecia totalis, the head area is involved completely, but not the other areas. In alopecia universalis, whole body is involved in alopecia areata. More detailed classification include disease duration, extent, description of pattern of hair loss. For example, in emphasis, prognosis is very poor in childhood, alopecia totalis and universalis. These all three conditions, in all these three conditions, there is very poor prognosis. Investigation. The number first investigation is the biopsy, especially in case of early onset and diffuse scarring alopecia. Second investigation is fungus culture. Third is the serology of lupus erythematosus, serology of syphilis, and screening for autoimmune disease. As I have already discussed, there are lots of other diseases which are characterized by alopecia areata. So we will investigate all these conditions. Management options. Here, counseling of patient and family with reassurance is very important, and give them advice that regrowth of hair cannot be occur before 3 months of therapy. We usually give hydrocortisone 25 mg per ml and triamcinolone acetonide 5 to 10 mg per ml. Minoxidil, anthraline diethyronol are also used. Prognosis in long-standing cases is very poor. So the first line management include clobetasol in lotion form or shampoo form for 3 months at least. Second is the hydrocortisone 25 mg per ml, triamcinolone acetonide 5 to 10 mg per ml, minoxidil, and anthraline, or you may say diethyronol. These are used as a first line therapy for the management of alopecia areata. Second line management include oral corticosteroid. For suppose if a patient is not responding to first line treatment, then switch to the second line treatment. The second line treatment are oral corticosteroid for 6 weeks. Tapering dose starting from 40 mg per day. The first start 40 mg per day, then taper it slowly and gradually. Prednisone 200 mg once a week for 3 months is mandatory. Contact immunotherapy. This is most effective and best documented treatment. It includes DNCB means dinitrochlorobenzene, or DABE and DPCB. So these are contact therapeutic agent. More centers now use DCB mechanism. It involves antigenic competition, stimulation of T cell response, increased expression of TAFB in skin. Phototherapy. Using all PUA, or you may say solvents, and that is either local, topical, oral, or whole body, is effective in 60 to 65% of the cases. It gives good response. Side effects include temporary lymphadenopathy, urticaria, and vitiligo. Thank you very much. Stay connected. Subscribe my YouTube channel for more information. Thank you.